Good evening, everyone. And I think everyone has received the file, the unannotated one. Just drop me a message. Is my audio and video okay? And then we can proceed. Shamim, good evening, Bache, good evening. So, uh, now what I am trying to do is like in the upcoming sessions, I am compiling topics from the recently concluded INI-CET and the FMG June 2026. So, okay, so just in the hope that like the recently asked topics, the students are good with those, right? So I have compiled a few topics for today's session. Good evening, Bache, good evening. So we'll start with the topics, then few important lines from that topic. We won't go for the entire detail, just few important topic points related to that topic, and then this will be followed by some practice questions, right? So the very first topic which I am taking today is the posterior interosseous nerve. Now, posterior interosseous nerve is classically associated with fractures of the radial head or dislocation of the radial head. So whenever you have a question in which if there is any mention of any injury in the area of radial head or radial neck or in the area of supinator muscle, think of injury to posterior interosseous nerve. So as it is related to radial head, so if there is any fracture of the radial head or if there is any operative intervention for the radial head or if there is dislocation of the radial head, there are more chances of injury to the posterior interosseous nerve. Now, one important thing is that posterior interosseous nerve is a purely motor nerve, right? It is a purely motor nerve. It means there is no sensory loss. So sensory loss is absent, only there will be paralysis of some muscles and that will be manifested clinically, but no sensory loss. Now, I think most of you must be knowing that if there is paralysis of posterior interosseous nerve, the resultant deformity is known as the finger drop, right? So there is finger drop deformity. Now what happens in finger drop? There is inability to extend the metacarpophalangeal joint. Okay, so there is inability to extend the MCP joint and there is no loss of sensations. So I'll write preserved sensations is the hallmark of posterior interosseous nerve palsy. So there is finger drop, there is no sensory loss, and finger drop is what? Finger drop is inability to extend MCP joint. And one important point which one should remember is that the wrist extension is possible, right? So wrist extension is possible because one of the muscle which can bring about wrist extension is extensor carpi radialis longus. Okay, so this is the extensor carpi radialis longus which is intact, and since it is supplied by the radial nerve, so it can function. So therefore what we can see? We can see slight dorsiflexion of the wrist, although there will be some radial deviation. So it will not be a clear cut wrist dorsiflexion. There will be slight radial deviation as well because of the action of ECRL, that is extensor carpi radialis longus, which is supplied by radial nerve, right? So this is in short which you need to remember for posterior interosseous nerve. Now let us take few questions and let me check whether you understood the concept or not, right? So there is a 38-year-old carpenter which has progressive weakness in extending the fingers of the right hand after repeated use of a screwdriver. On examination, he is unable to extend the MCP joint of the fingers and the thumb, but wrist extension is preserved and there is slight radial deviation. Then there is no sensory loss over the dorsum of the hand. Which nerve is most likely affected? So I think now the concept is pretty clear. We have already discussed if there is weakness of extension of at the MCP joint with preservation of wrist dorsiflexion with preservation of sensations, the answer has to be posterior interosseous nerve. So very good. The answer here will be posterior interosseous nerve. Okay. So the classical keywords are what? Inability to extend MCP joint. This is what we call finger drop. Okay, so this is the finger drop. Then wrist dorsiflexion possible, and we discussed this is possible because of which muscle? ECRL. And sensations normal. So the moment you have these three keywords in your question, the answer has to be posterior interosseous nerve, right? Then second question is slightly difficult. Now let us see what the question is. A patient develops weakness of finger extension, right? And that occurred because of proximal radial fracture. Proximal means it is either radial head or radial neck. Then MRI demonstrate compression of a nerve as it passes through the fibrous arch of supinator muscle. Now, which structure is responsible for this entrapment? Now, this is slightly difficult. Now, here, what is the clinical presentation? There is weakness of finger extension, and whenever we have this word, it means we are discussing with a case of finger drop, right? This is one thing. Then there is proximal radial fracture. So proximal radial fracture means it can be head or neck of radius. So overall, what is happening? This is a classical case of injury to which nerve? Injury to posterior interosseous nerve. So that we can understand. Now the question is actually anatomically integrated, and the examiner is asking like which structure is causing entrapment of the posterior interosseous nerve, and here supinator muscle is also given. So this structure is actually arcade of Froese, right? So this is arcade of Froese. So please remember arcade of Froese for entrapment of posterior interosseous nerve. So this is slightly difficult. Next question. A surgeon is operating near the neck of radius and there is injury to the posterior interosseous nerve. Now, which muscle is spared? Means which muscle is not going to be paralyzed. So, this is operative procedure around neck of radius, and we know that in this area there is high chances of injury to the posterior interosseous nerve. So here you have to answer one muscle which will be spared. It means it will not be paralyzed because it is not supplied by posterior interosseous nerve. So out of the options, can you answer which muscle will be spared? I think we have already discussed this. That muscle is actually doing wrist dorsiflexion. So that is extensor carpi radialis longus. So this muscle is supplied by radial nerve, so it is spared, right? So in posterior interosseous nerve, extensor digitorum, extensor pollicis longus, extensor indicis, all muscles will get paralyzed. Very good, bache, very good. Option D, ECRL. It is supplied by radial nerve and therefore it will be spared. Chalo, moving forward to the next topic which was asked recently, and this was about the deep branch of ulnar nerve. A very important topic. Almost every year, every exam, you can expect one question from this topic. Now, just like the posterior interosseous nerve, deep branch of the ulnar nerve is also a pure motor nerve. And when I say pure motor nerve, it means it is supplying only muscles. It is not giving any cutaneous sensory innervation, only muscles. There are many muscles which are supplied by the deep branch of the ulnar nerve, and important group is interossei. Now we know that there are two types of interosseis, palmar and dorsal. So the palmar interossei are responsible for adduction of fingers, bringing the fingers closer towards the middle finger. So you can remember it like pad. P for palmar interossei, AD for adduction. And dorsal interossei, they are responsible for finger abduction, taking the fingers away from the middle fingers. So this is dab. So pad, dab. This is the mnemonic which is very commonly taught. So palmar interossei, finger adduction; dorsal interossei, finger abduction. Now deep branch of ulnar nerve also supplies the medial two lumbricals, right? Medial two lumbricals, and these muscles or the lumbricals, what is the action? It is flexion of MCP joint and extension of IP joints. Flexion of MCP joint, that is metacarpophalangeal joint, and extension of the interphalangeal joints, but of which fingers? The ring finger and the little finger. Clear? Ring finger and little finger are supplied, the lumbricals acting on the ring and the little fingers are supplied by deep branch of ulnar nerve. Clear? That's very important. And since deep branch of ulnar nerve is a purely motor nerve, so there will be normal sensations. So preserved sensations with muscle paralysis suggest an isolated injury of the deep branch of ulnar nerve. Clear? So two purely motor nerves we discussed: posterior interosseous nerve presenting as finger drop, and deep branch of ulnar nerve which is also a purely motor nerve. Now let us take few practice questions, and this will make you understand the concept even more nicely. So one of the question is, a 30-year-old man sustains deep laceration over the hypothenar eminence while working with a glass. Okay, so there is a laceration over hypothenar eminence, and that is because of glass injury. On examination, he is unable to abduct and adduct his fingers, and there is weakness of thumb adduction. Sensations over the little finger and the medial half of the ring finger is completely preserved. Which nerve is most likely to be injured? Now here I think everyone can answer this. There is an inability to adduct and abduct fingers, number one. Number two, there is weakness of thumb adduction, and lastly and most importantly, normal sensations. So it means we are discussing one nerve which is purely motor, and therefore even though that nerve is paralyzed, sensations are normal. Now when abduction adduction of the finger is not possible, it means interosseous are paralyzed. And we know that what is the nerve supply of interosseous? Palmar interosseous, dorsal interosseous, all are supplied by deep branch of ulnar nerve. Also, thumb adduction is gone, it means adductor pollicis is paralyzed. Adductor pollicis is also supplied by deep branch of ulnar nerve. So ultimately, what will be the answer to this particular question? It will be deep branch of ulnar nerve. Is that clear? So please study this topic nicely. It is one of the very favorite topics for exam setters. So this is deep branch of ulnar nerve. Purely motor nerve, no sensory loss, only adductor pollicis or interosseous gone. Now let us take one more question from this topic. During surgical exploration of the palm, the deep branch of ulnar nerve is identified as it curves laterally across the palm. It accompanies which of the following arteries? Now this is slightly difficult question, but the answer is very easy to remember. So the question is about deep branch of ulnar nerve. Okay, so this is about deep branch of ulnar nerve. Now how you can remember this? Remember deep for deep, right? So this is deep palmar arch. Okay, so deep branch of ulnar nerve and deep palmar arch. So this is how you can answer this particular question. So it accompanies deep palmar arch. Deep branch of ulnar nerve accompanies deep palmar arch. So moving forward to next question. A patient is unable to adduct the thumb. The patient is unable to adduct the thumb while gripping a sheet of paper between the thumb and the index finger. There is compensatory flexion of the thumb's interphalangeal joint during the test. Now the question is about which muscle supplied by the deep branch of the ulnar nerve is primarily affected. Now this is one very favorite topic for exam setters. Now let us see what is being tested here. The patient is told to grip the sheet of paper between the thumb and the index finger. Clear? So it means it is kept in first web space. Okay. Now what is being told, that we are checking adduction of thumb, right? So we are checking adduction of thumb. Now, how it is checked? We tell the patient to adduct the thumb close to the index finger, and if the adduction is proper, it is very difficult to remove that sheet of paper. So if adduction is okay, it is very difficult to remove the sheet of paper. Now sometimes what happens, if this adduction is not possible, how the patient is going to hold the sheet of paper? He will flex the thumb at IP joint, and this particular test is known as book test, or clinically this sign is the Froment's sign. Clear? So the patient flexing the thumb to hold the sheet of paper, this is the Froment sign, and this is a classical sign of loss of adduction of the thumb, which is brought about by adductor pollicis. And adductor pollicis is supplied by deep branch of ulnar nerve, right? So here the answer will be adductor pollicis muscle, which is supplied by deep branch of ulnar nerve, and if that muscle is paralyzed, or if the nerve is paralyzed, obviously the patient will be using some other muscle to hold the sheet of paper, and this muscle is actually flexor pollicis longus, okay, which is supplied by anti-interosseous nerve, which is a branch of median nerve. So this is a very important topic, book test or Froment sign. Clear? So moving forward to next topic, and nerves around the hip, or the especially the thigh region. Now one of the important nerve is obturator nerve, right? Obturator nerve. Then second important nerve is the femoral nerve. Now obturator nerve is commonly injured during pelvic lymph node dissection or radical hysterectomy, that is removal of the uterus. So these are the two possibilities, two clinical scenarios where there are high chances of injury to obturator nerve: pelvic lymph node dissection or radical hysterectomy. Now obviously the muscles which are supplied by this nerve will get paralyzed. Obturator nerve as such, it supplies the adductors of thigh. Clear? It supplies adductors of the thigh, so there will be weakness of thigh adduction. Clear? There will be weakness of thigh adduction. Is that clear? And it will also cause sensory loss over the medial thigh. So obturator nerve, sensory innervation along the medial thigh, and the adductors of the thigh, especially the adductor muscles like adductor longus, adductor brevis, and the adductor part of magnus, not the hamstring part. Now classically this will present as difficulty in crossing the legs. So because adduction, so crossing the legs. Now if suppose these are the two legs, now what is crossing? Like one leg will like this and the other will go like this. So crossing will be difficult. It means adduction is weakened. So that's the classical feature of obturator nerve palsy. Then another nerve which is very important from exam point of view is superior gluteal nerve. Now superior gluteal nerve, it supplies abductors of thigh, namely gluteus medius and gluteus minimus. Okay, and therefore, if there is any paralysis of superior gluteal nerve, there will be weakened abductor mechanism of hip, and that will lead to Trendelenburg gait. Clear? Trendelenburg gait. Femoral nerve, it supplies the anterior compartment of thigh. Sartorius or the quadriceps femoris, right? And here the quadriceps femoris is the extensor of the knee joint. So obviously, if there is any femoral nerve injury, that will lead to loss of knee extension and diminished patellar reflex. So this is classical for femoral nerve injury. So obturator, superior gluteal nerve and femoral nerve injury. Now let us discuss few MCQs. A 26-year-old man sustains a stab injury, right? Stab injury inferior to the inguinal ligament. On examination, he is unable to extend the knee and patellar reflex is absent, and there is sensory loss over the anterior thigh and the medial aspect of leg. Which nerve is paralyzed? So I think again it's a very easy question. So there is stab injury by a knife below the inguinal ligament, right? Now what has happened after this? Unable to extend the knee. Then patellar reflex is absent, and moreover there is sensory loss where? Anterior thigh and medial leg. Now this is all about injury to which nerve? Obviously this is the femoral nerve, because extension of the knee is possible because of quadriceps femoris, which is supplied by femoral nerve. Patellar reflex is also absent, and then the sensory loss in the distribution of femoral nerve, that is anterior thigh and medial aspect of leg. Clear? So this is classical for femoral nerve. Now let us take one more question. A 68-year-old thin multiparous woman presents with intermittent bowel obstruction and pain radiating from the groin to the medial aspect of the knee. So the pain is radiating from the medial aspect of groin to the knee, and there is an obturator hernia. Which nerve compression is most likely here? So I think it's very easy here. So what is happening here? There is obturator hernia, and classically patient is having pain going from groin to medial aspect of knee. So this is pain radiation. So this is actually a classical house-shaped Romberg sign of obturator hernia. So the pain is going from groin to the medial knee, and this is because of compression of the obturator nerve. Now obturator nerve supplies both knee joint and as well as hip joint. So that referral, the pain is referred from the region of the hip joint to the region of knee joint. That's because both the joints have the common nerve supply, obturator nerve. Now this is again a very important question, has been asked many number of times and slightly different from the topic, but let us take this question. A 42-year-old obese man complain of burning pain and numbness over the anterolateral aspect of thigh. Symptoms worsen while standing for long duration and improve on sitting. Motor examination is normal. Now which nerve is compressed? So here the patient is an obese patient. Now what is happening here? There is paresthesia. Paresthesia means altered sensations like burning, needle prick, numbness, right? So that is paresthesia. Now where is paresthesia here? In which region? It is anterolateral thigh, anterolateral thigh. Now this increase with standing over long periods, and this decreases on sitting. Motor examination is normal. Motor means no muscle paralysis. So motor examination is normal. So this is a classical case of compression neuropathy. It means some nerve is being compressed and therefore there are symptoms of paresthesia, right? So now anterolateral, this is all territory of the area Stark. Yes, you are right. You are right. So this is lateral femoral cutaneous nerve. Yes, you are right, Arya. So this is lateral femoral cutaneous nerve. So classical presentation, and yes, this condition is known as meralgia paresthetica. Clear? So this clinical condition is meralgia paresthetica, especially seen in obese people or who are wearing tight clothes. There is compression of the lateral femoral cutaneous nerve behind the inguinal ligament, somewhere around the region of anterior superior iliac spine. So this is meralgia paresthetica. There is only paresthesia. There is no muscle paralysis. Clear? Very favorite for exam setters. So moving forward to next question. Again, this is very important from a surgery point of view. Anatomy of inguinal canal. Now here we should know the boundaries or the structure which are forming the different walls of the inguinal canal. Now anterior wall is formed by external oblique aponeurosis. External oblique aponeurosis, it forms the anterior wall. Then posterior wall, it is formed by transversalis fascia plus conjoint tendon as we go towards the medial side, right? So transversalis fascia on the lateral part and conjoint tendon in the inner part. Okay, so medially means inner part. Then the roof is formed by the arching fibers of the two muscles, that is internal oblique and transversus abdominis. Okay, so the two muscles forming the roof of the inguinal canal, and floor is formed by a ligament which is traveling from the anterior superior iliac spine to the pubic tubercle, and this is the inguinal ligament. Clear? So please remember these boundaries or the walls of the inguinal canal. Now conjoint tendon, as the name here is conjoint, so it means there is a mixing up of the tendon of two muscles, and those two muscles are internal oblique and transversus abdominis. Clear? So please remember this much, and this is the basic content which you should know while you will be studying inguinal hernia. Now based on this, let us take few surgically integrated MCQs. A surgeon performing an open inguinal hernia repair asks a resident to identify a structure that forms the deep inguinal ring. Which of the following is the correct anatomical description? So here you have to answer which structure forms the deep inguinal ring. Now suppose if this is the inguinal, if these are the two openings of the inguinal canal, right? So one is the deep inguinal ring. Okay? So this is the deep inguinal ring, and this one, say, is the superficial inguinal ring. So this is the superficial inguinal ring. Now remember one thing, these openings are never present in any muscle. That's important thing. Now deep inguinal ring, it is present in fascia transversalis. So deep inguinal ring is present in fascia transversalis, and superficial inguinal ring is present in external oblique aponeurosis. Okay? So if the question is about deep inguinal ring, what do you have to answer? It is an opening in the transversalis fascia or fascia transversalis. Okay? So this is the deep inguinal ring. Superficial inguinal ring, it is in external oblique aponeurosis. Fine? Please remember this much. Then moving forward to next question. Now a first year surgical resident is asked to identify the contents of inguinal canal in a male cadaver. Which of the following structure traverses the entire inguinal canal but does not enter through the deep inguinal ring? So the question is about a structure which is traveling through the inguinal canal but is not entering through the deep inguinal ring. So here, because there is one possibility that structure may enter from deep inguinal ring, will travel like this and then will come out like this. This is one possibility. Sometimes what happens, a structure might enter like this and then it might come out through the superficial inguinal ring. So the question is asking you, like, what structure is this which is traveling through the inguinal canal, coming out through the superficial inguinal ring, but is not entering through the deep inguinal ring? So the answer here, Arya, very good bache, this is ilioinguinal nerve, right? So ilioinguinal nerve travels through the inguinal canal, comes out through the superficial inguinal ring, but does not enter through the deep inguinal ring. So this is the ilioinguinal nerve. Next question. During a viva examination, a medical student is asked about the anatomical boundaries of the inguinal canal. Which of the following structure forms the roof of the inguinal canal? So, roof of the inguinal canal. Now, I think everyone can answer this. We have already discussed what forms the anterior wall, what forms the posterior wall, what forms the floor, and what forms the roof. So, yes, anyone? Now, here the question is about the roof. So, let me take it like this. Say, suppose this is the anterior wall, this is the posterior wall, okay, and then obviously this is the floor here, okay, and then the roof, something like this. So, this is the roof. So, anterior wall is external oblique aponeurosis. Posterior wall laterally is fascia transversalis, medially is conjoint tendon. Roof is by the two muscles, and those two muscles are the arching fibers of internal oblique and transversus abdominis. So, this forms the roof, and obviously the floor is by a ligament. So, floor is by the inguinal ligament. Clear? So, Umesh, very good. Clear? So, this is how you need to remember the boundaries, the walls, the structure which forms the deep inguinal ring, structure which forms the superficial inguinal ring. So, inguinal canal anatomy is very important, because when you will go for surgery, this is definitely, especially for inguinal hernia, the whole anatomical concept will be discussed again. So, please remember this, and therefore, it is very hot favorite for exam setters. Now, moving forward to next question, and this is about the ligaments injuries around the knee joints, and this is also very favorite and very common nowadays, actually, sports injuries. So, now here what you need to remember, there are actually three structures. So, one is the cruciate ligaments, pair of cruciate ligament, then the two meniscus, and lastly the collateral ligaments, the pair. So, cruciate is again anterior, posterior, meniscus are medial and lateral, and collateral ligaments are also medial and lateral. So, these are the 6 important structures which are very frequently asked in exams. Now, let us start with the meniscus. So, which meniscus is most commonly injured? The answer is actually medial meniscus. So, medial meniscus is commonly injured, and why? Because it is firmly attached to the medial collateral ligament, MCL. So, what happens? It does not get enough time to escape crushing between the femoral and the tibial condyle, because it is firmly attached to the medial collateral ligament, and therefore in clinical practice the cases of medial meniscus injuries are far more as compared to the lateral meniscus injury, number one. And how this is clinically checked? There is tenderness along the joint line on the medial side, and painful knee flexion on squatting is suggestive. Now, ACL injury, this is the one which is very frequently asked in exams, anterior cruciate ligament. Now, there are 2 important clinical tests which you should know, which are done for clinically testing anterior cruciate ligament injury. One is anterior drawer test, and the other one is the Lachman test. Clear? So, the other one is the Lachman test. So, these are the 2 tests which we do for anterior cruciate ligament injury, and the basic difference between the two is that we simply the degree of knee flexion varies. Here it is only around 15 degree, here it is somewhere around 90 degree. Clear? And we look for anterior translation of the tibia over femur. So this is how we check anterior cruciate ligament. Similarly, if the question is about posterior cruciate ligament, what we will do? We will do a posterior drawer test, and we will look for posterior translation of the tibia over femur, or what we can see is a posterior sag sign. So sometimes we can see the leg going, or the tibia going behind the knee joint, right? So that is known as posterior sag. Then the one which is very frequently asked is the classical unhappy triad of O'Donoghue. Very good, Arya, which is very good. Yes, very good. So this is anterior cruciate, then medial collateral ligament and medial meniscus. Clear? So anterior cruciate, medial collateral, medial meniscus. So please remember this. This is very frequently asked. Very good, Arya Bache. Chalo, let us take few practice questions. A 24-year-old football player sustains a twisting injury to the knee, okay, while his foot is firmly planted on the ground. Examination reveals a positive anterior drawer test and a positive Leishman test. So which structure? Yes, very good, Arya. I think everyone can answer this now. So there is a history of twisting injury. Clear? After this, there is the clinical tests are positive. So positive anterior drawer test and a positive Leishman test. So this is a classical case of anterior cruciate ligament injury, and we are checking anterior translation of the tibia over femur. Chalo, next question. A 30-year-old motorcyclist is involved in dashboard injury during a road traffic accident, and on examination the posterior drawer test is positive. Yes, Arya, very good. So I think it's pretty easy to answer. There is a dashboard injury and a positive posterior drawer test. Clear? So the answer is posterior cruciate ligament. So see, this topic is very important but very easy to score. So please understand the concept and don't make any mistake. Then next question. A 28-year-old rugby player sustains a valgus force injury to the knee. MRI demonstrates a tear of medial collateral ligament. Now, which of the following structure is most commonly injured simultaneously because of its attachment to the medial collateral ligament? Now, here there is a valgus force injury. Now, valgus, what do you mean by the word valgus? Means lateral. So the leg is pushed laterally and therefore there is strain over the medial collateral ligament. And we discussed before that since the medial meniscus is fixed to the medial collateral ligament, so therefore it cannot escape injury. So along with medial collateral ligament, there is high possibility of injury to medial meniscus, right? So this is how you will go for the answer as medial meniscus. Arya, yes, if it is about Odonog unepitried, then we could have taken ACL also. But otherwise, along with MCL, high chances of injury to the medial meniscus. Okay, so this is enough for today's session. Tomorrow I'll take few more questions of anatomy with some PYTs of anatomy from head and neck, brain and other regions of anatomy, right? So that's enough for today's session. Thank you very much for joining and see you tomorrow.